Good evening, everyone. The topic that I will be speaking on the challenges that we face in phakic IOL surgeries. Uh, to start with, I have no financial interest, but these are the phakic IOLs that I do. I do a lot of care groups IOL, the star ICL, and less of the ICRL phakic and the upper IRL that I have started very recently. Uh, the challenges that we face can be divided into the four challenges that we normally see: the calculation challenges, the sizing challenges, the surgical challenges. That's I'm going to show some of the videos regarding the same, and the post-operative challenges that we face, even if the surgery has been uneventful. The calculation challenges per se starts right from the patients who are high myopes. They have a lot of pseudo myopia, accommodation spasm. So that's where we always tell all the workups has to be completely done under cycloplegic refraction, because even if the patient is having around, we have seen 3 to 4 diopters of pseudo myopia, and that can land them into a post-operative refractive surprise. The challenges that we face most is in the patients with the keratoconus or post LASIK ectasias, because the refraction itself is the stringent task in them. They will have varying of refractions, and calculating having a good refraction in them is the major task in them. And obviously, when I talk about the SIAs in the phakic IOLs, that's fairly less in normal corneas. We hardly consider SIAs. It's been lot research in the past in 2012-13, but the SIAs in ectatic cornea will be fairly more as compared to the SIA that we see in these ectatic corneas. For example, if I'm planning an in a keratoconus patient, a phakic IOL, the first and the foremost thing that I would require is a long stability of a cone following a C3R. Unless you have a good full documentation of stability in a cone, perhaps straightforward, it's a no case for a phakic IOL. Once the stability is achieved, the outcomes are fairly good. One more challenge that we face here is the K values are 58, 61, 64. These will land up and give you a ACD which is falsely very high. Always deduct some amount of anterior chamber depth and then send it for calculation. So suppose if your ACD is showing 3.6, that's a false ACD. Perhaps you send for the calculation as per 3.3 millimeter ACD, so that you get a lens which is having a fairly normal vault as compared to what otherwise you would land up with. And usually we land up, what's a normal wall that we target is usually around 400 to 800 microns, although it's 250 to 750 is what is normally we used to target earlier. But now with the lens rise and the other factors coming into play, a target which I normally keep is around 400 to 500 microns vault. Sizing challenges, we have lot of challenges while we are calculating the white to white measurements, as it was elaborated by the previous speaker as well. A digital caliper, a well calibrated digital caliper is the must. And also, not only that, whenever you're ordering a digital caliper, it has to be a mini digital caliper and not just a digital caliper, because mini digital caliper are very easy to handle. They are just 3 inches or 4 inches. You get it easily on Amazon and will give you very easy thing. One more thing that you can do is have the Shermer strip there. You can calculate it using the Shermer strip as well. And ACD measurements, as I told, in keratoconus, you have to be very particular. S2S measurements using UBM in patients where you get a lot of variability. Like if you get a different white to white from the optical biometer or the topographer, and your manual digital caliper is absolutely different, it's always better to go for the sulcus to sulcus measurements in those. The vault challenges, as I said, you have a normal vault, a 758. I would consider it absolutely normal. In fact, better vault. And the smaller vaults like 119 would be less, and more than 1000 would be something which is abnormal vaults. A white to white measurement is the most important thing, and I always emphasize it has to be done under the microscope, with the patient in supine position. Take a speculum. It has to be done by two observers. Now that's very important. It has to be done by two different observers. Take three readings, make it to the caliper to the 0 point again, press 0 so that it's calibrated, and that's how you take the accurate white to white, and then adjust the white to white as given by different devices. We had done recently around 165 eyes of the patients, where we found that the white to white given by the pentacam was not statistically different from what we were getting by using a digital caliper, and that gave us the vault, post-operative vault, between 400 to 800 range. So two devices, manual, digital, wide to wide by two observers, always under microscope, and STS whenever in some cases. If the vault is high, if the vault is more than 1000 microns, perhaps rotation of the lens in the vertical position, if not toric, can be done. Or perhaps, when in doubt, please exchange the lens then and there itself rather than landing up into complication. If the vault is too low, less than 100 microns, perhaps a straightforward case, you have to explant and exchange it. It's around 150, 200 or a little more. Observe very closely because the central vault is different than the mid peripheral vault. The central vault may be around 100, 200. The mid periphery may be little lesser, particularly in high myopes and those with a lot of toricity in them. So always see the mid peripheral vault more than the central vault, because central vault nowadays comes with an aqua port or the central hole, so the oxygenation will keep on happening. The mid periphery is the area that's going to affect the most. The ACD measurements can be done from any of the devices, and almost all of them are fairly equal. In hyperopic patients, keep an ACD of at least 3.2. It said 3, but at least you should have 3.2. More than that would be a very ideal case of doing a hyperopia. I have limited experience in doing hyperopic, but whatever we have done as of now, holding well, and you require a PI. uh, I will just show two or three small surgical challenges that I have faced. One is that we always nowadays go with the 2.8 incision. Sometimes the difficulty in the injecting the lens. In all these cases, it is very important. Slightly enlarge the incision so that it goes very easily. Particularly the star ICL, please make an incision up to 3 millimeter so that the injection becomes absolutely smooth and more predictable. Now, what happens in some cases is the inverted insertion of the lens. This was used as a piggyback, and the lens goes in very nicely, but suddenly the haptic gets stuck between the cartridge and the plunger, and that's where you kind of land up into an inverted phakic IOL. Now, for this, what we had changed over the past is to start having a second instrument. Now, this is last two videos, they are very important here. Is whenever I am putting an phakic IOL, just give me 1 minute. These are very important. Huh? So I put a guard from the Vukix manipulator goes in first. The Vukix manipulator acts as a guard there, and I inject the phakic IOL. Now, suppose in case it is not opening in the way I want to, my first target is to make sure it is well away from the endothelium. I hold it, the phakic IOL there itself, simply give the injector to my assistant, take the second instrument. I usually keep two Vukix manipulator, keep the lens very much away from the endothelium, and simply rotate in the way you want to rotate it. The lens is very much away from the endothelium. I have another video which exactly shows how much away it is from the endothelium. I want everyone to just focus on the bubble that's at 7 o'clock position. Now, as we are injecting the lens, perhaps going a little faster than I would normally do, and it's not opening the way I want to, perhaps just about to flip open. I am just keeping the using the Vukix manipulator lens there itself. The bubble comes into play here. The bubble will be showing us the different gap between the endothelium and the lens again. This is where my second instrument, Vukix manipulator, will come again, and that space is very well maintained and it opens in the way I want to. So hereby we can prevent the flip by still staying away from the endothelium.
Can you please
Post-operative,
sum up?
yes, done. I will sum up here. This is the last video which I would say, and then perhaps I will close. It's a 80-second video. Hyperopic IPC, hyperopic phakic IOL. It would be perhaps seen here. It had an optic capture, and we are planning to take the patient to the OT for just repositioning the lens. But I told my fellow to just go up and take a picture of it. She started constricting the pupil with the high beam light, and we were absolutely fortunate that the optic capture was completely reversed just by using this particular light. So you will see that here it goes, and the patient still comes for follow up. No need, we didn't have to do anything for this particular optic capture. Thank you so much for your kind attention.
Thank you.